Hi, my name's Claire. I'm an occupational therapist, and myself and my colleagues have been invited to speak to you today about the profession of occupational therapy. We hope by the end of this session that you'll have a better understanding of what we do, and hopefully may inspire a few of you to consider occupational therapy as a future career. I'm going to start by giving you an overview of OT in general, and then I'll hand over to my colleagues Scott, Poppy and Christabel, who will tell you a little bit more about what it's like working as an OT here at the Birmingham Children's Hospital. There should also be some time to take at the end to answer any questions you might have. Okay, so I thought I'd start with a photo of us, the team at Birmingham Children's Hospital. It's the most recent photo I could find, and as you can see, there's quite a few of us, but not everyone's here. So we've got a good group of therapists in Children's Hospital. Okay, so that's our little motley bunch of therapists at the Children's Hospital. So I thought it might be really helpful to start with finding out what you know. So I'm going to ask you a couple of questions, if that's all right, and I'm going to just get you to use the chat box just to give me an indication, first of all, if you've heard of occupational therapy. Just either an emoji, thumbs up, or a yes or a no would be great, just to get a bit of a feel for if you know what occupational therapy is. Brilliant. Oh, that's good. Hey, lots of yeses. Perfect, perfect. Oh, I like that emoji, Shane. Perfect. Okay, I've got another question for you. So if you know a little bit about occupational therapy, I'd quite like to know, in the context of occupational therapy, what you think an occupation might be. Okay, so in the chat box, I'm going to give you some suggestions of what we might think an occupation is or isn't. And so I'll give you some numbers from 1 to 5 of suggestions, and I want you to, oh, we're already ahead of the game. Normal day-to-day activities, wonderful, Sana. So the suggestions are, and I just want you to write down the numbers of the ones you think are an occupation. The first one is getting out of bed. Number 2 is working in an office. Number 3 is writing notes in class. Number 4 is doing a paper round. And number 5 is brushing your teeth. Out of those 5 numbers, which do you think would be occupations that we would look at? All of them, yeah, yeah. Are any that jump out at you, Sana? Don't worry if you're not sure. Brushing teeth, yeah, definitely. All of them. Great. That's really helpful to get a bit of a feel. So yes, the ones that we specifically look at, we would look at all of them. They all are occupations, but particularly when we're talking about everyday activities, which Sana mentioned at the start of the chat, we're specifically looking at everyday activities. They're all occupations. So that's great. That's really helpful. Okay. So let me explain it a bit more. So as an OT, I provide practical support to empower people to overcome barriers preventing them from doing everyday activities or occupations that matter to them. And by problem solving and using creativity and working with an individual, I hope to understand what they want to achieve and try and get to grips with issues that they face to try and figure out how I can support them. And that might be, what I'm looking to do is help them to increase their independence and overall well-being and satisfaction in all aspects of their life. So in a nutshell, what we're looking to do is help people to live, not exist. So our occupations, as you sort of correctly noted, are made up of occupations which are meaningful everyday activities. These occupations can be and can include sleeping, making a cup of tea, completing schoolwork, or shopping with our friends whenever we're able to do that in the future. But occupations are everyday tasks, like you've mentioned, and they allow people to live independently and have a sense of identity. And that's why we think occupational therapy is so important, and that's certainly why we love it. As an occupational therapist, I look at the world through the eyes of the person I'm working with. And I focus on the areas of their life that they find difficult and challenging and hope to help them to overcome those challenges. They might be needing them to help with physical assistance or psychological support, or I might be helping them to consider changing a person's living or working environment. As an OT, I hope to have a positive impact on the people I work with. And I certainly work with children and young people that have a rheumatological or inflammatory condition like arthritis. There are other OTs that work with working age adults or older members of the community. And they might find that they have difficulties in doing activities that they want or need to be able to do. And that may be as a result of a physical condition, a mental health issue, an injury or disability, or due to frailty. So what makes a good OT? So I've got questions for you. Are you a problem solver? Are you good with people? Do you get a buzz out of helping others? Are you good at sizing up a situation? If you tick any or all of those boxes, please consider OT as a profession, because you'll definitely have all of the building blocks to making an excellent OT. So how do you become an OT? So there's four programs that you can sort of consider to become an occupational therapist. And so you would look to complete a pre-registration degree course that's offered in 30 universities around the UK. The first one being a 3-year undergraduate full-time course. There's also a 2-year full-time program for graduates, so people that already have a degree. And there's also 2 sort of 4-year longer programs that are either part-time or sort of delivered under the degree level apprenticeship program, all of which mean that whichever program you select, you become a qualified therapist, and it involves placements as well as university taught programs. So once you've become an OT, there's a sort of a variety of areas that of sectors that you can work within, and that ranges from working in schools and universities to within a hospital like we do in the Children's Hospital, to working in prisons or in the community. And certainly from my point of view, that variety of sectors that we work in really was attractive when I was thinking about OT as a career many years ago. I'm going to hand over to Scott. Hopefully he is here. If not, we're going to skip to Poppy, I think, who's going to talk to us a bit more about working as an occupational therapist, specifically within the Children's Hospital.
Okay. So as children's occupational therapists, we can work in quite a wide variety of settings. So it's not just hospitals. We can work in nursery schools and colleges. So you would tend to find us in specialist nursery schools and colleges, but kind of as time goes on, we're becoming more visible in mainstream schools and colleges and universities as well. We can work in community health. So that's kind of out and about in the community, helping children and young people with any kind of difficulties they have in accessing the community, or making their way to school, or completing daily activities, such as like using cutlery and handwriting. We can work in CAMS, which is Children and Adolescent Mental Health Services. And there we help children and young people with mental health difficulties, so maybe anxiety, to use the strategies that they offered by other health professionals, so mental health workers. They offer them strategies, and then we as occupational therapists help them to use them in the reality of trying to kind of access an activity or an occupation. We can work in private practices. So some occupational therapists work independently from the NHS and run their own businesses. So the picture, which I don't know if you can see properly with the kind of time and stuff, but there's like a colourful room with a swing. So something you might find in a private practice is that occupational therapists might look into and consider children who have sensory processing differences and how they can access the world and the environment around them to find things easier. And then finally, as we all do, you can work in a hospital as well. So that can be a specialist children's hospital like we work in, or a more general hospital where they have children's wards. So yeah, the options of where you can work as a children's OT are quite wide and varied, and no doubt will keep increasing as time goes on. So to talk specifically about what I do at the hospital, so I am part of the Metabolic bone team, and we work with a range of conditions. So I've listed the three main conditions. So it's me and another occupational therapist. We work with children who have osteogenesis imperfecta, or OI. You can all maybe have a guess at what you think that is in the chat box whilst we talk about the others. We also work with hyperphosphatasia, which is more commonly called HPP, and a condition called achondroplasia, which is the most common form of dwarfism. So I don't know if anyone's willing to guess what osteogenesis imperfecta is. I'll give you 1 minute just in case. So it is a very complicated. It is a bone disorder. That's a good guess. Yeah, bones are formed out of shape. So the bones can be formed out of shape with that condition, and the spine can also be in a different position to how we would want it to be in all of those conditions. But osteogenesis imperfecta specifically, you might know as brittle bone disease. So it's weakened bones. Yeah, that's quite a good synopsis of what it is. So it's children whose bones form differently to the rest of us because they have a genetic defect in their collagen, and so their bones can be more fragile and their joints can have a bit more movement in them. And hyperphosphatasia, I'm not a huge expert in, but it's something to do with an enzyme deficiency where bones don't calcify as we would hope, and the bones are soft. And achondroplasia, as I said, is the most common form of dwarfism, and that's because the arms and legs, the long bones of the body, don't grow as long as they do in other people, so the person becomes short. So those are the three main conditions that we help and support with. And so I felt it was really important to let you know that our work in the Metabolic bone team, but I'm sure in other places, is definitely part of an MDT or a multidisciplinary team. And it's really important that all the members of that team are there, because if they weren't, then we would struggle as occupational therapists to achieve what we want to and the goals of the young people. So we work really closely with physiotherapy, and we tend to do joint appointments with them. And so we can both come with our expertise and help the young people to achieve things. There are consultant endocrinologists, which is basically a fancy word for someone that understands the enzymes of the body. But they so we have some specialists in osteogenesis imperfecta specifically. We are the specialist centre for HPP, and we are becoming a specialist centre for achondroplasia. So that's a service that we're building. But we are one of 4 places in the UK where you would be treated as a young person with osteogenesis imperfecta. So we have some real specialist knowledge here. So there's also orthopaedic surgeons who kind of do bone surgery and rodding and things, specialist bone nurses, radiologists who take the images. We have a social worker in our team who kind of helps if social situations can be tricky, where it's beyond my skills and knowledge. We have a psychologist and we have orthotists. I think it's important to recognise that there are lots of other people in the team and we can't achieve what we want to. all by ourselves, even though we are amazing. But we definitely need other people there to help us for it all to work. So what do I do specifically? So this is very much a summary of what we do, but just to help you understand what my day-to-day tasks might include. So we support with baby handling and development. So when babies are born with any of those conditions, we try and meet them as soon as possible. With some of the conditions, because we are specialist centres, we see children as far away as Plymouth, Oxford, Nottingham, like lots of parts of the country. And we try and see them as quickly as possible and make sure that parents and all the professionals around them know how to handle them safely and to protect them from injury. We assess and prepare patients for discharge after injuries or elective surgeries. So when you have a condition like brittle bone disease, it's quite common for you to fracture. And so young people come in, and if they've particularly fractured one of their legs, then we will help them and plan how they get home and make sure that they're safe and that they can do everything they need to do, such as getting washed and dressed and sleep and eat whilst they're at home. We support with inclusion and access in school. So when people hear of brittle bone disease, they can often attempt to wrap children and young people in a kind of imaginary bubble wrap. But it's my job and the physio's job to try and remove that bubble wrap and give people that work with, like particularly teachers, the confidence that actually young people can do more than we would anticipate. And actually we have to take an element of risk to let the young person develop fully, whilst we're also recognising they have a health condition. So we might also provide therapy to achieve independence in self-care activities. So as I briefly mentioned, the conditions also mean that sometimes the joints can have extra movement, and in the hand, because there's so many joints and we do so much with it, that can make things really tricky. And so we might help with cutlery skills or being able to fasten buttons or fasten laces and kind of taking everything into consideration with that. We can also offer advice on managing with a health condition and reducing the risk of injury or accidents. So that can be about educating parents when they first have a baby born with this condition, or educating other health professionals that haven't come across it before, or kind of educating and talking through the condition with schools and colleges as children and young people get there. And so there's lots of things. So the children can grow tired. So we kind of factor that in and work out how they can achieve everything they want to do without overtiring their body. So it's covered over here, but I think it's consider if equipment is necessary, particularly wheelchairs. So some of our young people, their condition means that they find it difficult to walk at all or for long periods. So we, as occupational therapists, will be involved in that consideration of wheelchairs and making referrals to the appropriate services to make sure that children and young people can get one if they need one. And then prepare, so sorry, it's all covered at the bottom, but prepare young people for transition to new schools and moving to adult services. So we are part of the team that prepare children for these big jumps in their life. So moving from primary school to secondary school or secondary school to college are huge jumps. And so we support them and spend some time preparing them for those big jumps so that they are able to manage and it's not so scary when they get there, because life can be challenging when you have a health condition. Pretty sure that's all of my slides. Yes.
Okay. So I think you probably get the chance to ask questions at the end, but the next few slides are from me. So my name's Poppy and I work in the burn service here at Birmingham Children's Hospital. I think the first thing I wanted to talk about was why I like occupational therapy in general and why I think it's important. So I'm going to ask for some audience participation, and can anybody put in the chat how they felt when we went into lockdown when COVID started in kind of March, April last year? Give a couple of minutes to see if anyone's got any thoughts. I think from the people that we've spoken to here, lots of people felt quite lonely when they weren't able to see people, anxious yet. Yeah. And once it had been sort of 4 or 5 weeks of not being able to do the kind of day-to-day things that you enjoy, How does that make you feel? Yeah. Uneasy, scared. I think we can feel quite powerless as well when we're not able to do the things that we like to do, or the things that we might even need to do. So like going shopping becomes more difficult, going to appointments becomes more difficult. And I think that's one of the reasons that's made me think about how important it actually is to be able to do day-to-day activities, because that's what it can be like when those things are taken away from us. And then how did you feel when it got to sort of May and June and things opened up again and we could do things again? So I'll give a couple more minutes. Huh?
No, oh, no, it's in
Yeah. I think definitely for me, it's like a feeling of relief again when we were able to do things. Yeah, happier. I think personally as well, I felt more in control and I felt more like myself when we were able to do things again. And I think for me, that's an example of why occupation is so important and why occupational therapy is so important, because as soon as you have an injury or an illness or something happens to you that means that your ability to do your day-to-day things that you have to, but also the things that you want to do, like seeing your friends and your family, when those things are taken away, it's really not very nice. And then when you get that control back again, it feels really good. And I think that's something really important that we get to play a part in OT. So I think this is just a definition of what occupational therapy is, which Claire has talked about quite a lot. But we see people when something has changed in their life, their circumstances or their health or something that means they can't do what they need to. And we help people to get those abilities back again. So this is how I got into occupational therapy. So for me, I did the 3-year undergraduate route. So I went to uni in London at Brunel University and I did 3 quite intensive years. So we do lots of like anatomy and physiology, lots of learning about creative activities, lots of learning about mental health. I thought it was a really good course. When I heard about OT, I was probably in year 9, about 13, 14. And so I did a week of work experience and the straight unit at Solihull, and then I did a few days at Heartlands when I was in year 11, which really opened my eyes to kind of what the reality is and how different the different settings we can work in are. So I think that's a really good idea when you've got the opportunity, obviously. I did a BTEC in health and social care, which I thought was really useful. It was a lot more practical than the A-level courses that I was doing. It was very hands-on. We went to visit lots of interesting settings like old people's homes, and children's centres and things like that to really understand how broad health and social care is, which I think has always been useful in OT. I did fairly standard A-levels and I did lots of weekend work as well, working with children and disabled adults, so things that would kind of get me used to the kind of skills that I need in OT. So I did lots of childcare. I did work at a climbing wall for a while, working with kind of disability groups and things like that. And that helps me quite a lot now to kind of think about the different contexts that we do occupation in. So why I love occupational therapy, you don't have to read this whole slide because there's quite a lot on it, but I think I sort of want to make the point that in some professions in healthcare, you can go and see someone and say, okay, I want to look at your foot, or I've come to ask about your heart, or I want to know about, I want to know about your condition. And in occupational therapy, we very much have the chance to say, I want to know about you. So there's lots of kind of the sorts of questions that we might ask here. So when we meet older people on elderly care wards, we quite often want to know what they like to eat, who the people are that they live with, how their relationship is with their family, especially if they look after them, what their home is like, what they used to do when they were younger, what they like doing, what kind of clothes they like to wear. I feel like you get to find out so much about a person and about their life, and you meet people from all different walks of life, and I think that's really nice. I think if you're a nosy person, occupational therapy is great because you can find out absolutely everything there is to know about a person, which is something that I really enjoy. And I think for the child on here, it's just a couple of things, quite diverse things we might look at. So like sometimes we'd ask about their social skills, about how strong they are, about their coordination, about like sensory needs, so how they tolerate the clothes that they wear, how they tolerate loud noises. There's just so many different things that you can find out about, which I think is really interesting. So I work in the burns department, so I thought I'd just give you a bit of an idea of why it might be harder to do day-to-day activities when you've had a burn, because I certainly didn't really know very much about it until I came to work here. So when you have a burn, you can get skin contractures. So can everybody see the picture here? I'm going to just hope that you can. Hopefully you can. So sometimes when you've had a burn, the way that your skin heals means that your joints can't move as much as they could before, so that can make it difficult to do things. If you have a severe burn, that can affect your skin or maybe even your organs. That might mean that you need extra medical care. So like some of our major burns might go home with stoma bags or being like peg fed or something like that. So then actually meeting their day-to-day needs is much harder. Having a burn can be really traumatic. So lots of the children that we see feel anxious or feel clingy, or they don't want to do things on their own. And that makes it really hard for them to get their independence back and for their parents to get their independence back as well. Can I see what's under here? I must be able to move this. Parents might feel very guilty about what's happened. Sometimes the accidents that children have that mean they get burns can be things that parents could have prevented. So quite often people get spilled by tea or coffee, people have accidents cooking, children can sometimes catch their clothes on fire with candles. Quite often it's things our parents think, oh, like, I should never have let that happen. And when they're feeling so worried and guilty about what's happened, it can be really hard to look after their child after that. So that's another reason why it might be more difficult for them to do the things they need to do. And burns can also leave big scars. So sometimes that makes it more difficult to move, like if they've got a contracture in the picture. And sometimes it just means that children feel really self-conscious. So sometimes they have scars that cover their face, or sometimes they have scars that have meant their hair doesn't grow back. So they might be missing patches of hair. Or sometimes they might have even lost sort of fingers or parts of their limbs that make them feel really self-conscious. And they wonder what people are going to say. And that can make it really difficult to go to school, to go out shopping, to go and see your friends, all of those sorts of things. So that's a massive simplification, but those are some of the things that we might look at. So then these are kind of some of the things that we might do for children in that situation. So burn contractures tend to happen because of the way a burn heals. So we get involved as soon as a child has had a big burn, sometimes even when they're in the operating theatre. So that's to make sure that we move all of their joints where they might be burnt, so we can go and stretch out their fingers or their arms, their elbows, knees, you know, everything to make sure that it's getting as much movement as it can. And we can teach them stretches as well to do. So with an older teenager or with an adult, we'd probably say you need to stretch this joint in this way this many times a day. But with young children, obviously they're not so keen on doing that kind of thing. So you have to be really creative and think, okay, what's a way that I can get them to play that will encourage them to use that? Or what can I say to the parents? You know, they need to push buttons, they need to pull their own clothes up. You know, there's all kinds of different things that you can try to make sure they move the joints that they need to. I think one of the nice things about pediatrics is that you really have to be creative to do that, which is quite fun. We try and make scars softer and flatter sometimes. So we have special garments that we measure for. So you have to take 100 measurements on a child and then they make them specially. And that's to put pressure on an area that's scarring. So sometimes scars can grow to be raised. And when you put pressure on them, they can go down, or it can prevent them from swelling up as much as they would, which helps to give the whole scar and the child's skin a better appearance in the long term. So that's quite an interesting thing that most people haven't heard of. We help children to practice all of the kind of movements that they need to and the kind of activities that they need to do by doing lots of playing and using crafts. So we might do lots of cutting and sticking, lots of colouring. We might do hanging things from door frames so that they have to reach for them, different kinds of games, lots of different really creative things that I think are quite fun. Like there's lots of jobs that you do when you're an adult where you don't get to do fun things like that. So I think that's a bonus, and obviously the children enjoy it as well. And that's something that's nice to do when they're in hospital with a burn and they might be having lots of painful treatments, lots of dressing changes, lots of things that they don't enjoy. To be able to do something really fun is a really nice thing to get to do. We also run events and encourage people to meet other people who've had similar burns. So there's kind of two benefits to this. So one of them is that the children get to meet other people who might be in the same position. They might feel less self-conscious when they've seen someone else who looks a bit like them, or they might be able to kind of problem solve when they're worried about going back to school. They might hear about somebody else's experiences and feel reassured, and that's really nice. But also the parents get to meet each other. So quite often when something bad has happened to your child or they've had an accident, you might think you're the only parent in the world who that has ever happened to. And it's really nice for us that we can help the parents to think, okay, it can happen to anybody, and you move past it. And I think that's one of the reasons why meeting other families is important as well. And we help parents sort of come to terms with what's happened. So we do have psychologists that work in burns, so they do the kind of, you know, really helping them to process the incident. But we help to understand parent situations in a way that means that they can hopefully prevent it from happening again, but also that the exercises that we're suggesting are manageable to them. So we get to know a family really well, and we can say, okay, this is how you can fit this into your routine. We'll ask other therapists to come and help you if you need it. or we can ask carers to come help you if you need it to begin with. We get to really know somebody's situation and make sure that the parents feel on top of what's happening before a child goes home. So I think that's a really kind of diverse range of things that we get to do, which we really enjoy. I'll hand over to Christabel.
Hi everyone, I'm Christabel and I work in hand therapy. So I'm just going to quickly go through, because I know we haven't got much time left, a bit about what I do. There we go. So I did A-levels along with everyone else, and I only heard and decided about wanting to become an OT when I was in year 12, so it was very late. I knew I wanted to do something in health, but I wasn't quite sure what. So I just went to my careers advisor basically, and we just talked about different options, and OT sounded like something that I would like. So I did some work experience with the Alzheimer's Society. I was a befriender for some elderly people with early onset dementia. And I also got some work experience at my local hospital with the OTs there. So then I went on to study occupational therapy at the University of East Anglia. And we had quite a few placements twice a year within that 3-year program. One of them was hand therapy. Funnily enough, at the time I didn't really like hand therapy and I just didn't see the point of it. But after I did had my first job as a junior OT, I also got another opportunity to do hand therapy and I really liked it then. So then I applied for a job at the Children's Hospital last year. And yeah, been here for a year working with children. So what is hand therapy? So it's essentially any non-surgical management of hand disorders or injuries. So this can be anything from a child getting their finger trapped in a door or having a really traumatic injury. I sometimes see children who've had, or teenagers who've had knife injuries. But also I see children who have had conditions that they were born with. So that can be missing fingers or perhaps injuries that happened during birth. So I see a whole range of conditions really. To be an occupational therapist, you need to have a good knowledge of bones, muscles, tendons, nerves, how they work. So lots and lots of biology. But also you need to be quite creative because especially in children's, you're working with children and and you have to be able to play as well as deliver or make something for the child. So yeah, you have to be very, very creative. So I work with lots of different people. The main people that I work with are the consultants. So essentially, if there weren't any therapists, they wouldn't be able to do their surgeries. And if there weren't any consultants, then we wouldn't really have any, we'd be limited in what we could do. So we're in communication a lot with the consultant surgeons, and we are able to help advise on surgery and the benefits that would have for a child in terms of how they use their hands to get dressed, to play, going to school and that kind of thing. We also work with physiotherapists, orthotists, dermatologists, radiographers, nurses, and yeah, just a whole host of people in the hospital. So I've just put a picture of I don't know, he's an American NFL football player, so American football, not British football, but he's quite famous, probably haven't heard of him before, called Shaquem Griffin, and he's pretty well known because he had amniotic band syndrome. So this is something that happened in the womb. Essentially it's pieces of thread or string from the amniotic fluid were wrapped around his hand, and so it didn't form properly. He's actually a twin, so his twin turned out okay, but unfortunately his mum had to make a decision about whether to remove the band from Shakem's hand. If she hadn't removed the band, there was a chance that the twin would die or something like that. So she had to make quite a big decision about it. So his hand didn't properly form, and actually at the age of 3, his parents made the decision to remove the rest of his digits. But he still went on to become a very successful American footballer. So it just shows that even though children can have lots of different conditions that they're born with and kind of don't have much choice over, they still are not limited by that and can actually be very successful sports players or go on to do whatever they want to do. And that's a big part of what we do when we're working with children and with parents, because they're very anxious about their children and worried that they won't do well in school and they won't be able to do the job that they want to do. But actually most of our kids are very creative themselves and just kind of find ways to get on with life, and we're just there to help them along the way as well. So that was a very brief introduction to hand therapy. There is a little video. I think we probably don't have time to play it. I'm not sure. But in your own time, the Royal College of Occupational Therapy have done lots of work in promoting OT. So if you just Google it and put in choose OT, then there's lots of case studies about where different people work, and I was able to put a little case study together in a video too. So yeah, you can have a look at that in your own time. So if anyone has any questions for me, Poppy, Claire or Scott, then please put them in the chat now. But thank you for listening. I don't know if you've got a thank you slide. No, you don't.
Okay, so if we have no questions, we'll probably end the session at that. For those of you wondering about a certificate, we will be sending you a link to an evaluation form. If you complete that, you'll then be issued with a certificate for attending the session. Oh, we've got a question. We've got a question from Zahara. Should you take A-level biology if you want to be an OT? Does somebody want to answer it?
Personally, I took A-level biology to AS level, and then I didn't like it, so I quit. They tend to ask that you have either biology or social science. So the unis that I looked at, so you could have biology or you could have psychology or sociology, and I kept psychology just because I found it a bit more interesting. But biology would help you with things like a better understanding of anatomy and physiology. I found that they taught you enough in the first year of uni to make up if you didn't do it. But you just have to have a look at different unis and they'll tell you what their requirements are. I don't know, did you?
Yeah, I took A-level. Oh, I took AS biology as well, and I also took sports studies, which I actually found more helpful in terms of the anatomy side of things.
I actually thought that as unacademic as it sounds, the BTEC that I did at GCSE level was one of the most helpful qualifications that I had when I went to OT.
Can we do an OT apprenticeship? Yes.
Yes, you can do apprenticeships after college. I don't know very much about them because they kind of are quite new and it wasn't an option when I was at uni.
They are new. I think we'd have to do some research on the RCOT website to sort of look at how you apply, but they're sort of fairly recently been offered as a sort of another route to do your training. But it looks like a really good way of doing it.
I think that people that have practical experience are so much better when they're newly qualified. So I think apprenticeships are a good route. I think it's hard to just come out of uni. So I work on a rotation. So I work for 1 year in one department and then I move, which means that before I went to burns therapy, I was doing hand therapy with Christabel. Before that, I was doing rheumatology with Claire. So you can have a job where you get to try lots of different things. And also, because you learn so much when you go to uni to be an OT, you can change quite quickly. So like, if I decided now I wanted to go and work in social services or in mental health, you probably can.
Yeah, same as Poppy. So I started off doing a rotation in an adult hospital. So I worked in A&E, just general medicine, trauma and orthopedics. So generally, most people start off doing a rotation of some sort so that they can see which area they would like to work in. And yeah, for me, I found that hand therapy was where I wanted to go. So I got a permanent position in a hand therapy place. But yeah, lots of people do lots of different things. And if I wanted to go into a different career, then I could definitely do that because we have those transferable skills.
Malhill's got a really good question. What challenges have you faced so far and how have you overcome them? I'm going to just briefly say that probably been qualified 20 years, and I would say the last 12 months have probably been the most challenging for me as a qualified clinician, just because we've never sort of lived through a pandemic in sort of our lifetime, and how we deliver our sort of therapy has changed quite considerably, but we've overcome it because we're really sort of resilient and we are able to move with change, and we're quick to use our skills to sort of work out how we can offer them in a sort of a more appropriate and safe way. So working online, I do sort of groups via sort of Zoom or via Teams. So we have a hypermobility education group that we run sort of virtually, and we also do virtual assessments when it's appropriate. But we have to do sort of risk assessments when we're sort of bringing young people in face to face to make sure it's appropriate and safe for them to be in the hospital environment. But I would say that's probably the biggest challenge for me. I don't know what you guys think, but this year has been really sort of interesting.
I would just say that one of the biggest challenges I have faced is when I worked in CAMS, OTs had never worked there before until about a year before I joined, and there was only 2 of us. And the challenge was to ensure that people knew and respected what we were able to do. And in doing that, we probably took on a little bit more work than we were able to do. So we had a lot of juggling to do. So that was a bit of a challenge to kind of fly the flag for OT in a new setting. But it's also really exciting at the same time that ultimately you get to create what it will look like for years to come in all probability. So yeah, that's what I would say.
I'm blown away that most of you, when we asked the question at the start of the presentation, knew what occupational therapy is, because that's not always the case. And if you do your OT training, which I hope some of you will do, helping people to understand and raising our profile is one of our passions, I would say, and we're always sort of trying to fly the flag of how brilliant we think OT is and why we love our jobs.
I didn't find it very hard to get a job after I qualified. That was one of the questions. I think OT it goes in and out of being a shortest profession, so they're pretty much always looking for new people. I don't know what you guys thought.
Yeah, so I graduated and then I actually took a 3-year kind of break because I did some other stuff and didn't want to go straight into work. But even after 3 years, I had 5 interviews and 4 job offers. So they're always looking for OTs, and as long as you're kind of not too picky about where you want to work and which city, then generally you will always get a job. I don't know anyone on my course that struggled to get a job at all.
No. Uni life. I think it is hard because when I went to uni, I had friends that did like English or, I don't know, like more traditional courses. And I found that they had lots of time to go out drinking. They had lots of free time. They had lots of study time. Whereas we were like on site 9 to 5 every day. And we were like on placement as well. So like in first year, when everybody else is not really doing anything, you have to go and work on the other side of your city. for long days, and like that's quite difficult. But I think it's also rewarding because you get to do lots of different things. There's lots of variation between on-site lectures, on-site practical seminars, and then off-site placement work, so you're always busy. And I think you just stay motivated by sharing with your friends on your course, and looking at the things that you enjoy. I don't know what you guys think.
So I studied at Coventry, and we weren't in 9 to 5. We were in a few times a week, but we were expected to do a lot of independent study, so a lot of reading at home. So our time was full, but it wasn't always at uni. But placements, yeah, are definitely a struggle on top of trying to study as well. But like Poppy said, exciting and full of new experiences, so it's all good.
And also, you know, when you're doing it, that you're going to probably get a job straight out of uni. Like that's one of the benefits of doing a practical vocational course, I think. Is the degree science-based?
So yeah, definitely, especially in first year. At least for me, I covered a lot of anatomy and physiology, and we had majority of our classes were with physiotherapists, and we would do a lot of cadaver sessions. So it means we would look at kind of human anatomy and look at the muscles and bones. And then, yeah, in second and third year, it was still science-based, but not so heavy. I think they just want to make sure everyone's got a good foundational knowledge of like anatomy and physiology in the first year, really.
I found that from a science perspective, there was like, yeah, anatomy, physiology, biology in the first year, and then my final year was very much about research methods and research science, which is just a different kind of being science-based. But yeah, I thought it was a lot.
And when you qualify, you carry on sort of doing your research and study.
Yeah.
You know, if you decide on a particular area like hands or like burns, then you would carry on doing your own professional development and your own research in your own time to sort of hone your skills, if you like. You don't, once you qualify, stop studying, if that makes sense. It's an ongoing, evolving way of building up your skills and expertise.
What's the biggest difference between OT and psychology within a hospital?
That's a big question, isn't it?
Oh gosh.
It's very practical. So we're looking at functional things. So like psychologists will help people to work through their feelings about things, and understand things, and you know they do all kinds of kind of mental health things. We're looking at everything from a functional perspective. So we might look at the way someone feels a certain way, but probably mostly in relation to how that affects what they can do, if that makes sense. So we get to do lots of practical things. Psychologists wouldn't do your like washing and dressing, everyday activities things. So I guess we're a lot more hands-on, and they're a lot more kind of knowledgeable in mental health.
And I guess with OT, sorry, it's a phone ringing. So we look at the person as a whole. So we consider the physical problem of the person, so whether they've got a health condition, a physical injury, and then we look at their environment. So that could be their school environment, their home, and then we also consider the psychological aspect as well, and their social aspect, like their family, friends, and how all of those components affect that person. Whereas I guess psychologists kind of mainly focus on their psychological side first before taking into account other things. Whereas we kind of have to take into account all of those parts of a person.
That's a very good explanation. Is it an emotionally stressful job?
Yes.
It can be at times.
I guess it would really depend where you're working. So my first ever job in community, paediatrics wasn't overly stressful, but when I moved to CAMS, I did come across some things that were quite difficult to deal with. But you'll find that in those types of settings, there's lots of support in place already, because everyone finds it difficult to talk about children's mental health or different areas of work. So you'll find that there's peer support and like employee support already like embedded in the place you are. But you can sometimes find it difficult emotionally. But you'll find that actually you learn you get taught the skills of how to deal with that at uni anyway, through reflection. So it's not something that you're constantly kind of upset about.
Yeah, I think that's a good explanation.
Every now and again, you might get upset about something, but there's support in place. It's not a daily upsetting.
Yeah, I would agree.
Job.
I think the things that make it upsetting, like the fact that sometimes really bad things happen and the fact that you get really invested, are also the things that make it rewarding at the end when things go well. And I think that you can cope with that, okay, if you work in a setting where there's a good culture of talking about it. So like if everyone I work with was like, yeah, I'm not bothered about children getting burnt, doesn't worry me at all, then probably we'd all be like feeling really stressed inside. But if you just discuss when you're worried about something, I think it makes it a lot easier.
Yeah, I think any job, firstly, working with people is going to be emotionally stressful.
Yeah.
But then when they've got a health condition on top of that, it's also going to be emotionally stressful. But yeah, as Poppy and Scott have said, we have really good peer support from other members of the team, but also I think as OTs we're quite good at just taking care of ourselves and being quite resilient, and then it's just always very rewarding when you do manage to successfully discharge a patient, or a patient gets to do something a goal that they've really wanted to achieve for a long time. So there's like the positive and negative sides of the emotions that kind of balance each other out.
Yeah, you end up thinking like that was really hard, but it's really worth it.
Yeah.
What are the most important skills you need to be an OT?
Claire, would you like?
Yeah.
I think one of the slides at the start was just sort of starting to get you thinking. So if you are think on your feet and are able to problem solve, you like puzzles, you are good with people, so your interpersonal skills are strong, so practicing those communication skills are sort of fundamental to being an OT, I think. So those sort of skills are really, really important. You get taught at university about other sort of core skills that you'll need, but if you have those sort of problem solving and interpersonal skills, they're the sort of foundations of being a really good OT. I don't know if you guys agree.
I think you have to be curious as well. Like you have to always think, well, why is that way? I want to know more about this. I think that makes you a good OT.
You have to be quite nosy.
Yeah. Wasn't even.
She did say that, didn't she?
If you're interested in people's lives, that makes you a good OT fundamentally, and you can learn everything else. But having that genuine interest in people and their situations is the thing that you have to have going into it.
There's definitely an opportunity for advancement and progression. So once you qualify, you sort of become a sort of what we refer to as a band 5 occupational therapist, and as you sort of advance and know the areas that you want to work in, you can progress to becoming a band 6 and a band 7, which are more and more experienced and specialised areas of the occupational therapy role. And then you can decide whether you want to go into sort of a managerial aspect of the profession or whether you want to specialise as a clinical specialist. So there is definitely progression within the NHS and in the private sector, I would imagine too. I was sort of thinking with my NHS hat on, but yes, there is progression.
And you can always change as well when you say like to a different job. You can do something completely different to get a new skill set if you wanted to. Like that's always an option, which is really cool.
OT, do you think the job is more about having experience and knowledge? Grades. I came to OT slightly later. I didn't come in straight from school, so I did have some life experience. So I think that definitely helped me, but I don't think that's an essential prerequisite to doing OT. It's definitely a balance between sort of life skills and knowledge.
I think like you need to have a basic level. There's grades that you have to get into uni, but I don't think being like book smart is the most important thing. Like I always had good grades up to A levels going into uni, and I don't feel like it made it that much easier. Like I think the experience that you get at uni of working with people and understanding different situations is the most important thing. But if you go into uni without that much life experience, that's fine because you'll get it while you're there. I think that's partly why it's so hard, because you go into so many settings, you meet so many people. So like experience is really important, but you do get it as well. And I think all of the academic things, so like the grades that you need to get and the anatomy and physiology you need to know, you could always build that up. You can always learn that. It's the life experience that I think makes you like really passionate and really strong as a practitioner.
Yeah. And also, so I could have got 10 A stars at GCSE and 3 A's or whatever it is now for GCSE 7s, or I don't know what the highest is.
Nine.
I could have got the highest grades, but then when you get your first job, you're at the same level as everyone else. So yes, it's good to study and do the best that you can do, but then you kind of all start off on the same playing field and just build up from there. So
I think the people that I worked with
yeah.
when I first qualified who had previous experience or had had relevant placements or had worked in healthcare or had had interesting life situations themselves was so much stronger than the people who got all A's and firsts. Like that's
yeah, so you need the balance of the two, I think.
Yeah.
Such good questions. I'm so blown away by how many questions we're getting. So good.
Is there any? There were.
It's been really good having the opportunity to speak to you. Hopefully we've inspired some of you.
Cool.
Yeah. Thank you for listening to us. Hope it wasn't too long.
Thank you, everybody.
Bye.
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 Bye.